I'm the Executive Director at the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who are funded underneath the same grant program through HRSA. There are 12 regional resource centers that cover specific states, and there are 2 national centers, one that covers technology and one that covers policy, which is CCHP. Know that all 14 telehealth resource centers work very collaboratively and closely together on joint projects. If you have questions regarding telehealth, I encourage you to reach out to your regional telehealth resource center. If they are unable to answer your question, they will reach out to their other fellow TRCs and somebody will be able to find an answer. And I like to say about 99.9% of the time, somebody does have an answer. And when they don't, someone will try to go and find one for you. A couple of housekeeping things for today's webinar. Know that your phone or your computer microphone has been muted. If you have a question, please put it in the Q&A function. Please also fill out our post-webinar survey. It really helps us when you fill out these evaluation forms. Today's webinar is being recorded, and that recording and the PowerPoint will be made available about 48 hours after today's webinar. And I also have to offer an apology. I realize that you will be listening just to me for 1 hour straight. So my apologies that you will just be hearing my voice this entire time, but hopefully I'll be able to provide you with some useful information and updates for you that will make it worth it. So let's just get into it. I need to start off with disclaimers because sometimes people get confused when they see the JD in my name. I'm not offering you legal advice or opinions on today's webinar. Everything is strictly for informational purposes. CCHP always recommends that if you have a legal question that you want to form a legal opinion on, that you seek out legal counsel. Also, if I happen to mention a product or a company, know that neither I nor CCHP has any type of relationship or financial arrangement with such a company or with such an operation. A little bit of background about CCHP. We were established in 2009 as a program underneath the Public Health Institute to be a California telehealth policy organization. An opportunity to become the federally designated National Telehealth Policy Resource Center through a grant from HRSA became available in 2012. We applied for that and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels on more specific telehealth or connected health projects. We also act as an administrator for the National Consortium of Telehealth Resource Centers, and we are also the convener for the California Telehealth Policy Coalition, which is a coalition of over 100 statewide groups that are interested specifically on California telehealth policy. So what has happened with policy during COVID? This is a 100,000-foot level overview of the changes that have been made around telehealth policy, both on the federal and the state level. And you're going to see some commonalities as far as like issue on which telehealth changes have been made. Now, for today's webinar, I'm really not going to cover a lot of those changes that happened back in March and, from March to about June of last year. There were numerous changes both on the federal level and on the state level regarding telehealth, and for the most part, a lot of them have stayed in place because the public health emergency is still in place. I'm not going to cover those. I'm just going to cover what some of the more recent changes have been and sort of what we may have to look forward to. Now, I did say this PowerPoint will be made available afterwards. If you do want that information of like what has happened back at the beginning of the pandemic, it is in the appendix. I do have slides of like those changes. Again, it's not every single change because there were just so many changes, but it's some of the major changes that happened like during in Medicare and some of the state changes. So again, if you want that information, we have past webinars on those recorded, both on the CCHP website and on the National Consortium website. But also, I've made those slides available in the appendix with this presentation, so you can access that after this webinar and just download that to look at those. But for the purposes of today, we're going to talk about more recent changes and also what to look forward to in the future. So these are just sort of your high-level overview of what has happened. Again, you'll see commonalities of like what's going on the federal level and on the state level. And the reason for that is that a lot of the policies that existed for telehealth were around reimbursement, and they usually fall around the sort of same areas in which they touched upon how telehealth could be utilized and like what sort of boundaries or what requirements or limitations or what expansions they were allowed for. So that's why you see like a lot of issues repeated on both the federal and the state level. There are other things too that aren't related to reimbursement that impacts the utilization of telehealth that there were temporary waivers on, and those were like licensing and also prescribing and privacy and security. Again, those are non-reimbursement issues, but they were issues that impacted telehealth that we saw relaxations around as well. So first off, we're going to start with like federal policy. So what's happened since then? And before we dive too deeply into it, I do want to spend a little time on this. So on the federal level, a lot of telehealth policy really centers around Medicare and what Medicare does. So that's your reimbursement policy. What will Medicare pay for? What services will they pay for? How much they would pay for it, etc. Now, to understand the Medicare telehealth or technology delivery services policy, they approach it in two ways. They have what they have view as telehealth, their telehealth bucket, and then this other bucket called communications technology-based services. The telehealth bucket and the policy set around that are policies, a lot of which is established by federal law. So it's in federal statute of like how you're going to be able to use telehealth and Medicare and get it paid for and what's covered, etc. So that's where you see your restrictions such as, oh, it needs to take place in a rural area. You can only use live video. It's only these providers, etc., etc. That's your permanent telehealth policy. It's embedded in federal law. CMS really can't do a whole lot around that on their own. They need Congress to change things in order for them to like do more with it. And that's your telehealth policy. CMS also has this other bucket of policy, which is called communications technology-based services. And these are services that utilize telehealth technologies to deliver those services, but are not considered telehealth in CMS's eyes. They're considered something that they call communications, they give them the label communications technology-based services. And because they're not considered telehealth by CMS, they're not held to those statutory restrictions that telehealth services are. And the way that they've explained how they differentiate this is they're saying like, essentially telehealth services replace in-person service. It's a one-to-one exchange with something that would have happened in person, whereas communications technology-based services aren't services that would necessarily take place in person. So for example, you see your remote patient monitoring underneath this bucket of communications technology-based services. So remote patient monitoring, you got a patient with hypertension, they're taking daily readings, maybe multiple readings in a day, and they're sending that information via technology to a healthcare provider who is, looking at it at the end of the day, end of the week, etc. That probably would not happen in person. You're probably not going to get somebody to go in multiple times during the day to get their blood pressure reading with like a healthcare provider. So that's what they mean of like, it's something different because technology now allows us to do this. It's not necessarily a service that we would have done in person, but technology gives us the ability to do this. So it comes underneath this other category of communications technology-based services, as opposed to telehealth, which is a replacement for something that would take place normally in person. The reason I'm spending so much time on this is because during COVID, this has gotten a little bit confused because in that communications technology-based services, they did allow audio-only phone even before COVID-19 hit. This was underneath a set of services called the virtual check-in services, where you could check in with your provider for a quick check-in, like either live video, store forward, or audio-only phone. So when COVID hit and they allowed audio-only phone, and it sort of got mixed up with telehealth because they were allowing some of those services to be done audio only phone, some of those in-person types of services, people started mixing the two together. So I just wanted to be very clear that these are, in CMS's eyes, at least in Medicare's eye, two very distinct areas, and they all have like their different codes and their different ways and like how you bill for it as well too. So federal policy changes, and this is also want to take a bit of a moment here to discuss how a lot of telehealth policy is structured, the reimbursement policy in particular. So a lot of existing established telehealth policies before COVID hit that existed was around reimbursement. So that's what's the majority of those policies are specific to telehealth that are on the books. It's about like what's covered, what's paid for, etc. And reimbursement policy itself is usually broken down into like four particular elements: service, location, modality, and provider. So this is where you'll see a lot of how the policy is structured and like what is allowed and what isn't allowed. So for example, let's say you're talking about a Medicaid program's policies, and they will say like, this Medicaid program will reimburse for what service? Telemental health services. Where's the location of the patient when that service is taking place? When the patient's in a clinic setting or a doctor's office. What's the modality being used to deliver service? When the modality is when live video is being used to deliver service, and who's the provider when it's being provided by a psychiatrist. So those are your 4 basic elements of like the policy, and that's where you saw a lot of the waivers and the changes. Is like it usually addressed one of those elements if you were talking about reimbursement policies. And Medicare made changes to everything here practically. So for example, for modality, they allowed audio only phone to be used. For location, they opened up the geographical limitation and also allowing the home to be used. So those were some of the changes that are being made. So far, they're all, for the most part, temporary. There have been very few permanent changes made to this point, but there have been a couple of them. Again, you will be able to access a copy of the PowerPoint, so don't try to strain your eyes reading all these, but this is just sort of a very sort of quick summary of like what existed pre-COVID on the federal level, what were the changes made, and what's been made permanent. And we'll get into like what's been made permanent so far. So again, don't strain your eyes trying to read that. So there's 2 ways of making things permanent. You have your administrative channel or you have your legislative channel. Administrative channel are changes that CMS can decide to make through like what's within their power to make. And that's usually through the physician fee schedule when you're talking about Medicare. So for those who aren't familiar, the physician fee schedule comes out every year. It's the policies that CMS proposes for Medicare for the following year. So last year, their proposal came out in, I believe it was like early August. It's usually in the summer at some point, like around July or August. In early August, with their proposals for 2021, for this year. Then they have like a comment period where the public can like put their comments in on like what the proposed changes are, and then they publish a final rule. So the final rule is like their response to those comments and also their decision of like, this is what we're going to decide for 2021. So that usually comes out around November. Sometimes if they're a little bit late, it comes out in like December, but it comes out before the start of the new year. So that is one route in which they can make changes permanent. It's that administrative route. The other route is the legislative route, and this is where you have to have a bill passed through Congress. And that's a little bit harder, but also that legislative route is actually where you would need to go if you want to make major changes, major permanent changes to the telehealth policy and Medicare. Because again, as I mentioned earlier, a lot of that is embedded in federal statute, and you need Congress to act on that. CMS really doesn't have a lot of control on a lot of those major changes. So what happened with the physician fee schedule? I know it's a lot of writing. Again, you will get a copy of the PowerPoint, or you can go to the CCHP website. We also have a fact sheet on this as well. So really the only sort of leeway CMS has as far as like what are those 4 elements on telehealth policy that, reimbursement policy that they can like really have some control over and, not wait for Congress to act, is around the services. What services are going to be covered if telehealth is being used? That's really the only way that they have like a lot of say in, and they don't have to wait for Congress to give them permission to do that. So what they did was they did propose some of the codes that are on that temporary COVID list that they said that they're allowing during the public health emergency to be provided via telehealth. They did shift some of those over onto the permanent list. So let's say the public health emergency ends tomorrow. These codes would still stick around. You can still provide them or provide these services via telehealth. And it's nice that they've had some permanent codes that, that they're putting on the permanent list, but it's not a lot. That's the list. It's, what is that? Probably like, 9, 10 codes. And the temporary list itself during COVID was like about 150 different codes. So not like a majority of them were put on the permanent list. So those are the only codes that they said would be put on the permanent list. And the way CMS decides on what gets on those permanent lists of service codes is they have 2 ways of like testing that. So to get a service on the permanent list, they have what they call a category 1 test or a category 2 test. So a category 1 test is if the code that's being proposed to be put on the permanent list is very similar to a service that's already on the permanent list. That's usually something that, they utilize themselves, that they're proposed to like put something on a permanent list. They said like, oh, because it's very similar to what's already on there. So we're going to say it passes the category 1 test. Category 2 test is a little bit hard and a little less defined. Basically, it's saying that you need to provide evidence that this code would, essentially you can provide it via telephone. It'll be just as good as you did it in person. So, but it's kind of vague. It's like, well, what evidence do you need us to provide? Is it like, 5 published studies? Does there need to be like a certain amount of like people who were in the group who received it in the study, or that type of thing? It's never really been made clear on like, what are the standards that would like get you passed through on the category 2 test. So that's why like historically you see like more codes being put on the permanent list because they pass the category 1 test. So these are like what's on the permanent list now. So these are codes that were on the temporary COVID list of eligible services that have now been made permanent. So they're on there. You can do that if the public health emergency is over. You can still provide these services and get reimbursed underneath Medicare. What they did, though, in the last physician fee schedule, I said that there were two categories, a category 1 test and a category 2 test, and how they decide on whether to put services on the permanent list. In the last physician fee schedule proposal, they created another category. They called it category 3. And this is their sort of temporary holding box of, there's a bunch of services that's on our COVID temporary list that we think could possibly pass a category 1 or category 2 test, but we need more time to study it. We need kind of more evidence. So we're going to create this category 3, and we're going to put these services into category 3. And, if the public health emergency is declared over one day, they'll still be in this temporary holding box, at least until the end of the year, in the year the public health emergency was declared over. So for example, if the public health emergency is declared over March 1st of 2021, these codes in this category 3 bucket will still stick around at least through December 31st of 2021. So because that CMS said that'll give us enough time to like study this a bit more, get a bit more evidence to figure out if, they qualify underneath a category 2 test or a category 1 test, so we can shift them over to the permanent list or not. And as you can see here, again, don't strain your eyes. You'll get a copy of this. A lot more of the services than what was on the permanent list. So this is your temporary holding bucket. Now, right now, we are still in a public health emergency. So that entire list of like those temporary codes are still valid because we're still in the public health emergency. This is just when the public health emergency is declared over that this will like kick in. So that's this other thing that they did on the physician reschedule. Now, you're probably wondering, why did I spend all the time with the communications technology-based services earlier in the presentation? It's because they also did a couple of things around the physician reschedule related to Ctbs. And that was making some clarifications because it was like kind of vague. Sometimes they were kind of vague in like how people were supposed to do things. So they made some clarification physician fee schedule, but they also opened them up. So beforehand, those Ctbs services were only allowed to be used by certain healthcare professionals. And now they've like clarified saying like, well, no, some of them can be done by others, like such as clinical social workers and PTs and OTs. So they did open that up a little bit. Like I said, that is not considered telehealth. It uses telehealth technology to provide those services, but it's not considered telehealth in CMS's eyes. So they do have that control to make it more expansive, and they don't have to wait for Congress to allow them to do that. So that was like another thing that happened there. A couple of other things that they did do that were related to some of the temporary changes that were made during COVID. So we spent a lot of time talking about reimbursement, but there were other changes that CMS enacted, such as maybe frequency limits on utilizing telehealth or supervisory type of relaxations that they did, where you can use telehealth to like supervise like a resident or something. So they made some of those changes permanent. One of them, or they adjusted them in some ways in a permanent fashion. So for one of them, for example, is like skilled nursing facilities. So before COVID-19, you can only have one telehealth visit every 30 days for a skilled nursing facility resident. During the pandemic, they changed it and said like they removed the frequency limits. So what they've made now as their permanent policy is they changed it from once every 30 days to once every 14 days. So it's not as expansive as it was during COVID, but it definitely was more liberal than what it was in a pre-COVID world. So those were a couple other changes that they've also did as well. But as you can see, they didn't really do like the big expansive changes such as, allowing the home to be an eligible originating site, allowing, the removing the geographical restriction, allowing PTs and OTs to provide telehealth permanently. That's because that's not within CMS's power to do that. They got to wait for Congress to do that. So then that leads us to the next channel in which you can make a permanent change, congressional action. So what's happened really in the last couple of months of making something permanent? There was the Consolidation Appropriations Act. I'm sure a lot of you heard this, but maybe didn't really like dive deeply into it because this was passed around right before Christmas, right around the holidays. So it may have not been like the focus for a lot of folks. But they did pass the Consolidated Appropriation Act, and there were a couple of telehealth things in there. Not a lot. And nothing that was really related to the temporary changes that were made in response to COVID. But there were a couple of telehealth things in there. So eligible originating site, they added another eligible originating site to the telehealth list, the permanent telehealth list. And these are critical access hospitals or other rural health facilities with less than 50 beds. And they're calling them rural emergency hospitals. That's the new label that they're giving them. So that is now a new eligible originating site for your permanent telehealth policies. They also added mental health services, diagnosis, treatment, evaluations can be provided without the geographic restrictions, and it can now be done in the home, but there is a caveat there. So I know a lot of people probably were very excited to see that, saying, oh, great, they're greatly expanding mental health services being provided via telehealth, but there's a big caveat there. They're saying that in order to do that, there needs to be one in-person visit with the telehealth provider in the 6 months prior to when those services are going to be delivered via telehealth. That really narrows your ability, because the thing about telehealth is that it can take place over great distances. So if you're utilizing a provider who is in, 100 miles from you, still in the same state maybe, but 100 miles from you, this means you need to go see them at least once in person before you can start receiving those services via telehealth. So it really was not as expansive as maybe on first viewing. It's because of that in-person requirement, which is really unusual because that was not required for any other telehealth services before. So I don't know if this sets a precedent of some sort. But it's not as widespread and as great as I think probably people were hoping it to be because of that in-person requirement. Now, does that mean that applies for all mental health services? No. Only if you're trying to remove the geographical restriction or have it done in the home. So if you're going into like a clinic, like let's say an FQHC, which is an eligible originating site, and you're in the rural area, you like meet all those other requirements, you don't need to see that mental health provider once in person before you receive services. So sort of like the original policies where you still have the geographic restrictions, the site restrictions and everything, you don't have that in-person requirement. But if you're trying to get out of geographic restrictions, and try to have it done at the home or like in not one of those eligible originating sites, you do have that in-person requirement. So a lot narrower than I think what a lot of people were hoping to see. Other things that were in there was like an additional $250 million for the COVID telehealth program through the FCC. So for those who may remember this, with the CARES Act last year, there was $200 million given to the FCC to do the telehealth program for COVID. A lot of that was like trying to get equipment of some sort into patients' hands. They added another $250 million to that. FCC is looking at how to try to rejigger that program to make it maybe a little bit more efficient, a little bit better. So it's still in the process of doing that. There's also a lot of funding for broadband. So there was tribal broadband funding, additional broadband funding itself. One of the things for broadband funding was like, I think it was called emergency services broadband. Basically, it would give subsidies to people to get like a broadband subscription, help with like $50 to $75 a subsidy to help pay for like broadband connectivity. So there were a lot of broadband things in there, a couple of telehealth things, but as you can see, actually none of like the temporary stuff that existed for COVID was in this last major act by Congress, the most recent one that actually passed. So that is something that I think might play into what I'm going to do when I do a little bit of future predicting as well. Other things that happened, this happened a little bit before the Consolidation Appropriation Act, and it's the PrEP Act declaration. This happened, I think, around Thanksgiving. So the PrEP Act declaration, there was an amendment to it. So the PrEP Act declaration is basically there to provide protection to providers when they're treating people during the pandemic for like COVID. And they're given certain liability protections for certain things. It's not for everything, but it's for certain things related to treating a patient for COVID. And they have these things that they call amendments to the PrEP Act, so which they kind of expand or change the policies a little bit. And this one was called Amendment 4, and it involved telehealth. So basically, what it said was that first off, it would put telehealth providers underneath their category of eligible providers who are covered by this PrEP Act. So that was the first step, saying like, okay, telehealth providers will be like these eligible providers. And then it said, if an eligible provider is providing services, specific services, what they call covered countermeasures, they're very specific narrow band of services to patients who are located in another state, those licensing requirements in that patient states don't apply to that provider. So basically it's saying if you are a telehealth provider and you provide a very specific type of service, and it's these covered countermeasure services to a patient in another state, you don't have to be licensed. Now, there's a couple caveats on there. So it's not like saying like all telehealth providers don't have to get licensed then in another state if there's like a licensing requirements. It's saying it's for a very specific situations for a very specific provider. So it's saying like if you're a telehealth provider, and when they say a telehealth provider, you have to be like a provider who can provide telehealth in the state that you're located in. You have to be acting within your scope, that type of thing. So you can't be, let's say, I don't think there's a state that has this, but for example, you have a state that says dermatologists can't provide services via telehealth. I don't think that exists, but let's just, for purposes of our example, say that is something a state has, where they say dermatologists can't provide services via telehealth. You would not fall underneath this as an eligible provider. But once you get past that hurdle, then the service that you're providing has to be a very, very specific type of service. It's a covered countermeasure, and it basically has to be related to like COVID. It's got to be a treatment for COVID. So it's not saying like, we'll use our dermatologist example again. It's not saying like, oh, if you're a dermatologist and you're treating a patient who has a skin rash because of a food allergy, that's not going to be like underneath this exception here. So it's very narrowed, it's very tailored, but it is interesting in that it's the first sort of licensure federal like relaxation that they allowed here. So I don't know how many people have taken advantage of this, but that was also something that came out late last year. Other federal actions that could be seen, this is me doing a little bit of predicting. I don't have any inside track. So again, this is just sort of my predictions on this. For one thing, well, this is not a prediction. This did happen. The public health emergency looks like it's going to be extended through the rest of the year because a letter went out from HHS, from the Biden administration to the governor saying like it's sticking around for the rest of 2021. So that's good. That gives people like a little bit of like security and knowledge of like we're not going to have this cliff effect of like, oh, suddenly the public health emergency is declared over. The letter also did say like, if we were going to do that, we'll give you about 60 days notice. So we're not just going to have this cliff effect of like, it's over like tomorrow and that's it. And then we just revert back to pre-COVID stuff. So that is like good news. What we're probably going to see going forward, I don't have a really good handle on like what the Biden administration wants to do with telehealth. It's not quite clear to me yet. But going forward, this is just a guess on my part, is that we're probably going to see a little bit of pumping on the brakes here. Like when COVID hit, there was like all this telehealth policy change. There was like this great expansion because we needed to do that to address the needs. But I think there's probably going to be a step back from policymakers now of like, they're going to be a little bit more sort of mindful and ask more questions about, like, what should we keep around? What's the data that's out there? There's going to be a lot, I think, increased calls for data. There's probably going to be more scrutiny about telehealth policy and like the impact and like, what would be kept around. And the reason I'm saying this is that because I think they're going to be pumping up brakes, because I thought if they were going to make something permanent, they would have taken advantage of the opportunity with the Consolidated Appropriation Acts back in December. So if there was like really this push to make something permanent, I thought it would have been in that bill. And the thing is that there wasn't anything in there, but these other types of things that weren't even on like the temporary list here. So that's why I feel like there may be a little bit more thoughtfulness or like a little bit more caution going forward on like what policies to keep around. And that's not just on the federal level. I think we'll probably see that a lot on the state level as well. Those states do seem to be moving a little bit faster than what's going on the federal level. And speaking of states, so before COVID-19, you had Medicaid reimbursement for live video. Everybody was doing some type of reimbursement in their Medicaid program. It was very narrow. It ranged from very narrow to like very expansive. Store for and remote patient monitoring, not as popular, and usually limited in some way. So for certain specialties, like for remote patient monitoring for like chronic conditions, and that's important to know, because if a Medicaid program was reimbursing for remote patient monitoring, that was probably a Medicaid program that allowed the home to be an eligible originating site. And that was probably it. Other programs that weren't reimbursing for remote patient monitoring, they may not have been allowing home to be an eligible originating site. One exception I can think of is California. California did not, before COVID-19, did not reimburse for remote patient monitoring, but they did allow the home to be an eligible originating site. But for the most part, unless they were reimbursing for something remote patient monitoring, most likely they were not allowing home to be an eligible originating site. Problematic during COVID. A lot of people were sheltering in place at home. You needed that to be an eligible originating site, which is why you saw a lot of policy changes on that, at least temporarily. Commercial payers. So a lot of states, the majority of states, have some sort of private payer law regarding telehealth. But again, it varied from state to state widely. It varied from, health plan, commercial plan, you can't cover telehealth if you want, all the way to a state saying, health plan, you shall cover telehealth services the same way you would in person. And by the way, you will pay the same amount for that service as well. And then everybody else kind of falls in between there. So that what we saw during the pandemic were some states that, outright ordered health plans saying like you're going to do that, like the extreme end of like you shall cover these services, at least for those that were related to COVID. But a lot of states were also saying you will cover like all services the same way you would in person via telehealth, and you'll pay the same amount. And you also saw health plans just deciding to do that on their own as well too. A lot of those policies about those commercial health plans, some of them have like gone away. They were time limited, and they've expired now, but some of them have like kept it around. There were certain pockets where policies or payers that like kept that as a permanent policy. So it like varies, like the policy landscape like varied like it does for the states of like, how different approaches are taken and what's stuck around. What we're seeing on legislative trends. So a lot of bills are being reintroduced that were introduced last year to like make changes permanent on the federal level. They've been reintroduced this year. Like the TREAT Act was reintroduced as well. Some of the other ones to like make some of these temporary policies permanent, like FQHCs as an eligible distance site provider. They've been reintroduced. Do I think they have a chance? Most likely not. I don't think like a telehealth bill solo on its own will likely get passed, but I do think elements of them could be like taken out and put into a larger bill, and a larger bill getting passed and that becoming law in that way. That's just because that's historically what's been done in the past couple of years. On the state level, the trends that we're starting to see now for 2021, we're starting to see a lot of bills looking for payment parity from private payers on the state level. So that's becoming a trend that kind of took a bit of a back seat over the last 2 years. It's starting to like make its reappearance again. Telephone, audio only phone, that is like been a major point of discussion both on the federal and the state levels with policymakers of like, do we keep audio only phone? What do we do about fraud? Is this as good as in person? We're starting to see a couple of states in their Medicaid programs make a permanent policy, but they've been very narrow in how they've done it. They've usually just sort of said, well, we'll allow audio-only phone if you're providing mental health or behavioral health services. So they usually tailor. It's not a widespread, we're going to allow it for everything. So more the norm has been like it's been for something specific. Licensure, also a big issue that happened during the pandemic, is, again, being looked at legislatively on the state level as well. So that's going to be interesting to see how that shakes out, because I think there were concerns during the pandemic. The sort of um, fix for that, or how that was addressed before the pandemic, was usually through compacts, licensure compacts. And I think some policymakers felt that did not really help too much during a pandemic. So there may be more action being taken, more aggressive action being taken on the policy level for that. Compacts are still around, but I think there may have been a desire to like maybe do something a little bit different than just relying on a compact. Requirements for regulatory boards to create regulations around telehealth. So that's also something we're starting to see as well. Prior to the pandemic, there were some regulatory boards, licensing boards that had guidelines or requirements on how you use telehealth. A lot of them were pretty broad. I mean, they were basically sort of like, you keep the same professional standards if you would have even provided in person. You make sure that the patient is who they say they are. You show them like your credentials to the patient. Those things, not really too onerous, and a lot of them like were very sort of like common sense type of things. So are we going to see like more explicit type of requirements coming from regulatory boards? We could. I mean, that's always like something that could happen, where the regulatory boards direct their licensees on like certain ways of like doing things. We also were starting to see a rise in questions about like, if you're a telehealth provider, should there be some sort of certification there, where you're starting to see a lot more groups crop up saying like they offer certificates or certification, which I say is like very different. So if you're somebody saying I'm offering you a certificate or I'm offering you a certification, very different standards on there. So like keep that in mind. And that's on the policy end, that's also needs to be kept in mind of like, what are you asking the provider to do? Are you just asking them to like attend a class and then they get this little piece of paper? Or are you asking them to go through this training where it's certified that they've like gotten the specific type of training? So that's something that like kind of cropped up during like the last couple of months of COVID. And that is it. These are a couple of resources on our CCH website. Again, we do follow the federal policies. That's the link to it, but we also follow like, what the states are doing. We have that categorized on our website as well. We have a newsletter. That's our email information. I mentioned the appendix here. See, this is all the CMS Medicare type of stuff. I said, if you want that, again, the PowerPoint will be made available. You can download it, or you can go to the CCHP website. We have that information on there too. And I'm happy now to take questions. So let me see what's in the Q&A box here. Let's see. So excuse me as I move my toolbar out of the way so I can read the question here. Will these numerous changes stay in place permanently after COVID? That's a good question right now, and everybody's in a bit of a waiting game here. My best guess would be some will probably stick around, but you're going to see some of these go away as well. If I were to guess, I would say definitely sort of like the HIPAA waivers will probably be one of the first things that go away. But some of the reimbursement policies, again, that's up to Congress. CMS really can't do much around like those Medicare big changes, the temporary big changes like the rural restrictions allowing FQHCs. We got to wait for Congress to act. And as I said in my presentation, I mean, I thought if they were going to do it, they would have done it with the Consolidated Appropriations Act. But, the face of Congress changed slightly with the election, and we have a new administration. So we'll just have to see. Maybe they'll go forward with it. I think keep an eye on the Reconciliation Act. You're going through that reconciliation. Maybe we'll see something there. So that's like the next big thing is like the reconciliation process they're going through right now in Congress. How would Ctbs rules allowance encumber a purely direct-to-consumer virtual org as opposed to an integrated brick-and-mortar virtual one? Do Ctbs rules enable traditional orgs more than they do entirely virtual ones? I think I understand the question. I don't think that there is an encumbrance? I mean, first off, if you're a direct to consumer organization, you would have to be, you know, a Medicare provider. You would have to get consent. So that's one requirement that you would have to get, that, you know, maybe a little bit trickier for somebody who's purely direct to consumer. Trying to think, was there an established patient requirement there? I don't think there was. I'm not quite sure. If I'm understanding the question correctly, I don't know if it is like more complicated for direct to consumer than it is for say like a traditional sort of like FQHC or a clinic or something. But you probably you know, one of the first things you need to do is make sure that you're eligible to Medicare provider. So that would be one of the first things. Does in-person requirement for telemental health mean that the person has to go in person every 6 months or just once before treatment begins? The way they wrote it, now, the way they wrote in legislation, it sounded to me like they just have to do it in the 6 months before the telehealth treatment starts. That was the way the language was written. I have not seen the policy of like how CMS intends to implement that. So that could be the tricky thing. There could be like all these other requirements because they didn't really put in the language that they couldn't put other requirements in there. I mean, like other sort of things. So the way the language is written in statute, it sounds like you just need to have that one in-person visit before you begin telehealth, not that you have to do it every six months. So like, for example, you have that one visit and then you start treatment via telehealth, and then it's like 8 months since your like last visit, do you need to get another one? It did not sound like it was required in that law, but again, we have to see how CMS is going to implement the policy, and they haven't come out with that yet. Another provider told me that he was reducing virtual visits because reimbursement was reducing in 2021. Is that true? I had not heard anything. First off, is he talking about reimbursement as reimbursement amount, or is he talking about reimbursement as what was allowed? So if he's talking about and I'm going to assume this is Medicare. So my apologies when I answer this. I'm talking about Medicare here because Medicaid and commercial payers, that all varies. So I'm going to look at this through the Medicare lens. If he is talking about reimbursement amount of like what he would get, that should not be reduced if he is doing a telehealth visit. Now, if he's doing a virtual visit and he is doing a virtual check-in visit, that's underneath your communications technology-based services, which they have their own different fee schedule. I don't think they're reducing the amount of that, but that is a lower amount than what would have been paid had the service been a telehealth visit. So there's that. Is he talking about reducing reimbursement as far as what's being covered in 2021? Again, if we're talking about Medicare, even though the public health emergency looks like it's going to go through the rest of the year, so that means all the services on that temporary service list should be covered. There's nothing that says CMS can't take a service off that temporary list. So that is possible that it could be reduced, as in that service may no longer be on that temporary list. So if that's how he's looking at it, that's possible. I'm not sure if I see that happening, but there's nothing that prevents CMS from saying, oh, this service that's on the temporary COVID list for being eligible for telehealth, we're suddenly just going to take it off. I don't see that happening, but there's nothing that prevents them from doing that. Joy, hi Joy. Does HR 133 mean that if we are now providing mental health services with the patient's originating site in home, that we have to have that patient be seen first? This is just for Medicare or Medicaid as well. Okay, so it's not for Medicaid, so you don't have to worry about that. That's a good question. So you're doing it now in the home. Well, no. So what happens is you still have the public health emergency. So you still have that, like, basically covering you for like the geographic and urban, the geographic limitation and like the home restriction. So the public health emergency will probably trump what's that. It's only like when we shift back into like permanent telehealth policy, when the public health emergency is declared over, that will probably kick in. So that would be my guess. Again, we haven't seen how CMS is going to implement this, so maybe they'll say something differently, but that would be my guess. It's like, because we're still underneath the public health emergency, you're still covered by that. And this permanent policy on mental health services isn't going to kick in, but we also haven't seen what CMS is going to come up with like how they're going to implement this. Again, not giving legal advice. That's just my opinion on how I'm reading it. So, hello, I'm a pharmacist in Connecticut. I know we are recognized telehealth providers here. We cannot bill insurances, still incident to billing only. Going to depend on what insurance you're billing. So, my guess is going to, again, depend on what insurance you're billing for and what you're billing. So if you're talking about Medicare, could you provide those services typically in person that are like on that eligible service list if you're a pharmacist and you would get paid by Medicare? So that's how you look at least for Medicare. If for your Medicaid program, commercial payers, it's going to vary. And I'm sorry, I don't know offhand, like Connecticut Medicaid, what they're allowing. And commercial payers, they all vary. And I wouldn't be able to tell you that. For the most part, because a lot of them keep their policies private. So I don't know what exactly they do a lot of times with telehealth. So it's gonna depend on what insurance you're trying to bill and what their policies are. Okay, let's see. Has CMS relaxed the originating site geographic requirement permanently for the circumstances where the patient comes to clinic, not designated as rural, to connect with specialists in another city within the same state, non-mental health? Permanently, no. That and again, CMS cannot relax that rule limitation. They have to wait for Congress to act in order for that to happen. So is it permanent, the geographical limitation permanent relaxed? No. Now, caveat to that, before COVID-19, there were some relaxations on the rule restriction for certain things, not mental health, for certain things such as stroke and end-stage renal disease. And end-stage renal disease services can also take place in home. So there were certain, like, exceptions, very narrow, very specific. But permanently remove the geographic restriction, no, that has not happened yet. Gotta wait for Congress. Are you hearing any congressional or Biden admin concern about recent fraud cases that had a virtual component that facilitated fraud and the impact it will have on keeping home as a originating site? When you're a policymaker, you always, the F word will always come up at some point with policymakers around telehealth, so fraud. So for that, I've looked at some of the fraud cases and, yes, there was a telehealth component, but it also sounded like a lot of those fraud cases would have taken place also in person, regardless of the telehealth component as well. So I'm not quite sure if telehealth makes it easier to commit fraud or not, because at least for the cases that I've read about, it sounded like, well, that happens in person too. They just happen to have used telehealth. I don't know if telehealth made it easier. So, but that's always going to be a concern with policymakers, both on the federal and the state level. So, telehealth advocates and proponents, just be aware of that. That's always going to come up. Is the PrEP Pact declaration retroactive? By retroactive, how far do you mean going back? So it kicked in, I don't think it's retroactive. I don't recall seeing anything in the language about it being retroactive to a certain point. I think that passed around November. So that'd be my answer. I don't know for certain, but I don't really recall offhand if I saw anything about it saying that the amendment would be retroactive to a date before the amendment was made. Will there be permanent changes to telehealth policies for substance use disorder treatment, assessments, routine services, especially in rural areas will reach more for COVID policies? So yeah, substance use disorder, opioid epidemic. I mean, people forget. We actually had two pandemics going on. We had the COVID pandemic. We also had the opioid pandemic going on as well at the same time. And yes, there was a lot of concern for those who were being treated for substance use disorder of they weren't getting services. Are there going to be permanent changes on that? If you're talking about federal level, I hate to be a broken record, but yes, we're going to have to wait and see in that we have to wait and see what Congress has to do, not yes that there's going to be changes. Basically, we're going to have to wait and see what Congress does. State level, I think you're getting a little bit more traction on the state level. So on the state level, I think there is definitely more interest and action that's being made forward. I mentioned earlier that the audio only aspect of being made permanent in some Medicaid programs but it was very narrowed and tailored because it was mental and behavioral health. Some of those is because of substance use disorder, for treatment for substance use disorder. So some of them you're seeing on the state level being made permanent. Federal, Congress, gotta wait for them. Next question. Can you share what is the status of ensuring that language access is part of telehealth services? The status of that, not quite sure what you're asking there. So language access, I know a lot of states. So I'm based in California, and there's just the state requirement that when you provide health services, you have to give them language access, like the language that they are, the language, the primary language of like the patient. So I'm guessing a lot of states, other states have that, but I'll be quite honest with you, that's not something that I've delved into, because that's not a telehealth law. That's just going to be like a healthcare services law in there. So if you are providing telehealth services and there is a law like that that exists in your state, you're still held to that. I mean, you don't get a pass because you're providing your services via telehealth. There are those other like healthcare laws saying like, you know, you need to like give language access, or, you know, if somebody has a disability, you have to give them access to that. Well, you've got to figure out a way to make sure that you abide by that law. I don't think any of those were waived. You know, again, not an area that I focused on because it didn't specifically relate to telehealth. But if you're providing services via telehealth, you still have to abide by those laws as well. So I know a lot of people tend to think like, oh, this is all I need to know about telehealth. It's like it's delivery of healthcare services. So those other healthcare laws that you have to abide by still apply if you're providing a service via telehealth. It doesn't automatically go away just because you've changed the method in which you're providing the service. Is there any effort ongoing to collect data that supports expanded use of telehealth? I'm finding many programs are collecting it, but no idea how to use it to expand policy. So yes, and yes, it is a little bit sometimes like scattershot in that like people are gathering it, but where's it going and who's doing a comprehensive study? I do know that there's been like, you know, some, I think federally funded studies like maybe through ARC that are looking at it a little bit more closely, not necessarily for the purpose of expanding telehealth, but really to examine the impact of telehealth of what it's done. So that is a caveat there, is that it's not necessarily being done to make the case that it needs to be expanded. It's just really a study looking at of like what's been the impact, how has it been used, et cetera, et cetera. But there are, I'm sure, also privately funded studies as well. There's been a lot around community health centers and looking at them because they have been on the front lines of a lot of this, and they have been limited in how they can use telehealth, both on the federal level and sometimes on the state level as well. But sort of like a comprehensive, it's pulling from like a different, you know, like nationally, I don't think I'm aware of one where maybe, you know, they're pulling, maybe a private foundation might be doing a study of some sort. But I agree, it's probably been a little bit not organized. I don't think anybody's like made that investment of like one major study. It's also a little bit hard. So when you try to like study telehealth with the data and say like, is it as good as in person? It's kind of like saying like, well, is it as good, is healthcare good for you type of thing, because it is healthcare and delivering it. So a lot of times when you do study and you try to study outcomes, you have to pick a sliver of saying like, well, was it as good as treating substance use disorder as it was in person, as opposed, and then, you know, it's difficult then to say like, well, it worked for X, but to make the whole argument of telehealth in general then, because if you did the whole study of telehealth in general, it is kind of like saying like, well, did healthcare make a difference? Because that's what it is, it's providing healthcare. Let's see, are you seeing any consideration of moving to value-based care in order to remain the home as originating site? There's been talk about that, but nothing definitive. Like I haven't seen a policy being proposed on the federal or the state level yet, like, you know, an actual, somebody's written that up. But it's part of the mix of the discussion of like, you know, does this work better in a value-based system as opposed to like, you know, fee for service where it is sort of like, you know, you're just paying for each service. So obviously the more service you provide, the higher the cost. Maybe value-based, it might be more efficient. There's always been a lot of talk about that with telehealth, but I haven't seen anything like definitive being proposed on the policy and either on the federal or state level, but that has been in like the discussions. Do you see any changes to interprofessional e-consults that are not considered telehealth, or are they considered Ctbs? Yes, at least for Medicare, e-consult falls underneath the Ctbs. bucket. And another reason why I spent a lot of time talking about Ctbs and making that distinction with Medicare is that that's been picked up on some level by the states as well. So they haven't necessarily called them Ctbs, but what you see on the state level is they've been replicating some of those reimbursement policies for Ctbs on Medicare within their Medicaid programs. Again, they're not calling them Ctbs. They've just sort of like maybe added them to their fee schedule, but we've noticed that as well. And eConsult does fall underneath that bucket there. For Medicare states, it's either just kind of hanging out there, or maybe some of them have like called it, put it underneath the umbrella of telehealth. So it kind of varies in like the state approaches to it. No questions, just extremely grateful for Mei's awesome expertise and updates. Amanda, thank you. And thank you for everybody for being patient and listening to me drone on for an hour. Chloe, do you foresee the private payers requiring specific telehealth software to be used? Ooh, maybe. So they may require, like telehealth providers, health plans may require that they use a specific platform. There are some states that are putting in legislation saying like, you can't do that, because there's been a concern, this happened before COVID, that if you have a private payer law in a state, that health plans have been pushing patients towards a third-party vendor that they have engaged with in a contract. Not dissing them, I'm using them as an example, like a Teladoc. Let's say a health plan has a contract with Teladoc, and they're saying, if you want telehealth services, you have to go through Teladoc, you have to use this platform. There have been states that have raised that as concern because you're not letting your in-network provider then use telehealth. So they have been passing legislation to not prevent that, but basically saying like, hey, you need to let your in-network providers also be able to offer telehealth services as well. So there could be that push on that software side of things as well. But some of the state policymakers, have been looking at that type of situation. I mean, it's probably still going to be an option for them, but they do want to ensure that the in-network providers also get a fair chance for utilizing telehealth and providing it to their patients too. What is the difference between 99334 and 99335? The descriptions you gave are exactly the same. I'm going to have to get back to you on that. So I just did keep in mind for like the slides, it is a little bit of a summary there. So there may have been the details. It's probably like a timing thing. There may be like a difference in time, but I don't know for certain offhand. We are in a federally funded free clinic in Florida. We are interested in starting to provide telehealth for patients for both primary care needs, but also for behavioral psych care. Since we are under a sovereign immunity agreement care, would all these regulations you discussed still apply for us? Interesting. So I am so sorry if I butcher your name. E. Palaza Ishrinax. My slide with our email address is up. Could you send your question to me so we can like look into that and get your answer back to you? I would also recommend, since you're in Florida, you contact the Southeast Telehealth Resource Center as well, just to be connected with them. But if you send me this question through that email, we'll take a look at it and dive a little bit deeper into it, because I can't answer it right now, but we'll follow up with you. Beth Cruz, in Washington State, all nursing professions, RNs and ARNPs are newly required to complete a training in in Washington, telehealth in order to provide services through telehealth after June 30th. I think that's the deadline. Ollie, this new rule was not applied to physicians. Yeah, so for those who aren't familiar, Washington State had like this new law that they passed, and like, if you're going to do telehealth, that you have to go through this training program. Actually, I think the West Regional Telehealth Resource Center helped try to get that training program up and running. I can't explain why they made the choice of not having the physicians there. My guess would be like lobbying purposes, but I was not involved in that. They didn't contact me, so I don't know of like the history of like what went on in the discussions and everything like that. But it is interesting that you bring that up, Beth, because that goes to like my certification comment that I made a few minutes ago, of like, are these requirements going to be now made on telehealth providers to go like through these programs? This is actually a piece of legislation that was passed. So it's in law that they have to do this. But that is like interesting that, it was like only for some professions and not for others. So that is also like another concern out there, is like, is that equitable, and like doing that if you're going to require this? Jennifer Schmidt, do you have any information or guidance on the timing of the SCC telehealth grant competition? I think they got a little bit more. They were getting comments back on how they should structure that, and that was a couple of weeks ago. So I think it was at the very least, it'll be like a couple more weeks, but probably maybe in about another month we'll hear. They'll send out like the application for that, but they were just taking comments just a few weeks ago. So I would think it would just take them at least a little bit more time in order to get it up and running and get the application in place. So I don't have like a definitive time on it though, but make sure you subscribe to the CCHP website. As soon as we hear anything, we'll put it out in our newsletter to let people know. We're actually at noon. I'm going to try to answer the last 10 questions that are in this box. So, and just to make sure we get to it, is the BAA waiver still on track to ending April 20th, 23rd? That's making it required for multiple entities to have. As far as I know, the HIPAA requirements, unless the OCR decided to change their mind, will keep going with the public health emergency. I had not heard about the April 21st deadline of that, but as far as I know, it should stick around for the HIPAA waivers for the rest of the public health emergency. At least that was how it was initially written. But keep in mind, they can change these policies and alter them like during the middle of the pandemic too. So that is something to keep a watch out for. When you discuss the requirements for one in-person visit within 6 months prior to telehealth use for mental health therapy, will that requirement kick in after the PhD is deemed over? I'm thinking it kicks in afterwards, but again, we have not seen how CMS is going to implement that. They haven't come out with their policies yet, so that's still a question mark. The way the regulation is, or the way the statute, the languages are in the legislation, I would think it was supposed to kick in after public health emergency is declared over, but we're going to have to wait and see what CMS says. Are the tribal broadband funds and additional broadband funding only for the time of the public health emergency? And how do we find out more about the implementation of these funds? Again, you can keep an eye on the CCHP newsletter, subscribe to that. As soon as we hear anything, we'll let people know. I don't think it's like PHE. I think if I remember correctly, it was, well, obviously in reaction to like the public health emergency, but I don't think it was tied only to the PHE, although the emergency broadband subsidies might have been. But the tribal ones, I'm not quite sure. I might have to get back to you on that one. So that one I'm not 100% sure about. During the PHE, will CMS increase the WRVUs for audio only tile to providers who are only paid by RVUs? I've not heard anything about increasing that. If you want to send me an email just to remind me that you asked this question, I can see if I can find out more information on that, but I haven't heard anything. It sounds like possibly the most broadly important advance for patients. Audio only is at risk of being reversed after the PHE. What's the most effective way for providers and the public to communicate the legislature on this? Basically, communicate with your legislator, communicate with your congressional representatives. If this happened on the state level for your Medicaid program, you want to keep it around, communicate with them and really talk about the impact it's had. If you're a provider, talk about the impact of patients and talk about why you did it. I'm hearing from policymakers is that their fear of it's just the easy option that providers are going to take. And at least in my experience with providers, it's not that it's the easy option. It was like the only option available for that particular patient because of whatever reason, usually because they didn't have broadband access. So explain the reason why and make it clear of why you're doing this. If it was the easy option, okay, that's probably not what they want to hear. But if it was I had to use audio only for my patients because they do not have broadband, we are in a rural area, I had no choice. It was either this or they go without. That's what they need to hear, because I think in some policymakers' minds, they just think, oh, it's just easy for the provider to do it over audio only phone. And I know that's not the case for everyone. You mentioned prior to COVID, one telehealth visit was allowed per month for nursing homes versus now during the national emergency being during the national emergency, skilled nursing facility visits, it's basically no limits. The permanent policy, once the public health emergency is declared over, is once every 14 days. So public health emergency, those relaxations still are in effect as long as the public health emergency is still in effect. But once that's over, then it's going to be once every 14 days. Hold on, let me get my mouse over there. Here's the new, okay, Beth, for those who can see the Q&A, Beth put in the new state law, Washington state law here. Thank you, Beth. And if there are post-pandemic changes, certain communities may have a more prolonged pandemic, even where other communities are still suffering after pandemic fest. Do you think Congress would consider extending the PHE for those communities? Not sure, to be quite honest. I don't know if they will like. Well, it's also the president and the secretary that declares the PHE. So I'm not sure if they would extend that, to be quite honest. That's one thing that, sorry, my crystal ball is not giving me an answer on that one. Sorry. Okay, well, dude, thanks for addressing. Shout out to okay, Beth. Yes, shout out to all the TRCs. So if you have not contacted your TRC, I highly suggest you do. And I think that that is the last of our questions. Thank you, everyone, for sticking around. I hope this information has been useful to you. You've got some good information, and thank you for putting up with my voice for 1 hour. The PowerPoint will be available. The recording will be available about 48 hours afterwards on the TRC Consortium website. You have the CCHP info email. Please send us an email if you have any questions that you think of later. Also, please fill out the evaluation form. It really helps us. We are HRSA funded. They like us to have that information. So please fill that out for us if you can. So everyone have a great day. Thank you for showing up. I hope this has been helpful. Talk to you later.